Hello, everybody. Welcome to this presentation about pain clinical endpoints biomarkers. My name is Petra Schweinhardt, and I'm based at the Biomarkers University Hospital at the University of Zurich in Switzerland. Many of you will be familiar with the Initiative on Methods, Measurement, and Pain Assessment in Clinical Trials, shortened to IMPACT. So IMPACT has been working on many years now on clinical trial endpoints for pain and also on the assessment of biomarkers. So they've provided a very comprehensive overview of different biomarkers in different domains. And they've identified neuroimaging, sensory testing, and skin biopsies as the areas that are potentially very fruitful for developing pain biomarkers. So for a comprehensive overview, I refer you to their excellent publication published in 2017 in the European Journal of Pain. So I am obviously not able, and it's not possible, to do a comprehensive overview in just 15 minutes. So what I'm offering to you today are some thoughts and analysis on neuroimaging and actually sensory testing biomarkers that I think are worth being considered, and that will hopefully then also instill some discussion. So let me start with neuroimaging, or how I termed it here, brain-based biomarkers. So if we consider pain itself being the problem, i.e. the disease, then that seems like a very obvious option because, of course, the sensation of pain is a brain function. However, then the question becomes what we would be using it for. So as you of course know, there are many different types of biomarkers. So a diagnostic biomarker being one of them. So a diagnostic biomarker of pain would allow for the detection of pain. So there are many people arguing that in most instances, this is actually not at all necessary because we can just ask the patient whether they have pain or not. And also such a diagnostic biomarker with its legal implications has, of course, potential side effects or potential issues associated with it. And Karen Davis and other people in different working groups have very eloquently written about this, for example, in this Nature Reviews Neurology paper. However, there's still a potential benefit of a diagnostic biomarker of pain that I would like to point out to you. And that would be if it was more sensitive than actually the verbal report of the patient. So that might actually then allow that, for example, treatment responsiveness of an intervention of a drug would be detected earlier. Irene Tracy's lab in Oxford has been working on this topic for a long time, and in 2015 they published a quite comprehensive paper comprised of different experiments that partly addresses this issue or this topic. So in these experiments they had 7 different fMRI studies that used known analgesics that we know work against these types of experimental pains that they were using. And in 5 out of those 7 fMRI studies, that actually detected an effect of the analgesic on the brain activation patterns. There was also an effect on the pain ratings, on the verbal pain report. However, 2 of the studies, there was only an effect on the brain activation, but not on the verbal pain report. And in 0 of the studies, and none of the studies, it was the other way around. So that seems to indicate that there is maybe really the potential that a brain-based biomarker, brain activation in this instance, is more sensitive than the verbal pain report. So that might be very useful. And I think conceivably, or from a theoretical perspective, that actually also makes some sense. Because if you think about it, the brain activation patterns ought to be the type of stuff that gives rise to the sensation of pain. So by looking at these brain activation patterns, we might actually be a step closer to the actual experience of the patient than by that verbal report, which requires yet some extra step of cognitive processing. The other type of biomarker that I think is very interesting in the context of pain and neuroimaging is what I term here a mechanistic biomarker. So let's assume we have 2 brains that experience pain, and the 2 people with those 2 brains both give a pain rating of, let's say, 7. So it's very much thinkable that different brain activation patterns, different types of connectivities, different network characteristics, whatever you have, are underlying this very similar sensation and this equal pain report. So such a difference would be akin to what in psychiatry is often called endophenotypes. So the strength of an endophenotype is its ability to differentiate between potential diagnoses that present with similar symptoms. So what has been done actually regarding brain-based biomarkers? As I said in the beginning, I can not possibly go through all the different things that have been suggested, and yet at the same time, none of the measures really has made to that grade of being a biomarker. So I want to spend a little bit of time on this by now quite old study of Vanya Karen's lab, but it was really one of the first ones putting this concept out. So I think it's worth being looked at. So in this study, what they did was they took a good number of patients with subacute low back pain, imaged them, assessed them also in other ways, and had them come back to the lab repeatedly over the course of a whole year. After 1 year, they looked who of those patients still had pain, so had developed persistent low back pain, and who of those patients had actually recovered. Then they went back and looked at the first time point of assessment in the subacute phase, what was different between those two groups, and what sort of brain signature would actually predict whether somebody would then still have a back pain a year later or not. So they find a pretty specific functional connectivity between the nucleus accumbens here in the brain and the medial prefrontal cortex, being able to predict who then a year later would go on to have developed persistent low back pain and not. And they were able to predict this with a relatively high accuracy. Importantly, they also had an independent validation group of patients in whom they used this identified biomarker and could actually show that the accuracy of now still predicting who would still have pain a year later or not was almost as high. I think that is a very promising study, and it has been created a lot of attention in the field. It has been cited a lot, it has been talked about a lot. Interestingly, it has not published so far by an independent laboratory. That is obviously something that is really important in the context of biomarkers. So what other suggestions have there been for brain-based biomarkers of pain? So I picked another one that I think might be actually the one that's most often reported, and that concerns default mode network changes. The default mode network is typically acquired or assessed in so-called resting state functional magnetic resonance imaging. And there have been several studies that reported these alterations in patients with chronic pain compared to those without pain. Even to the point that in several studies, similar sentences to this one quoted here have been written like chronic pain seems to reorganize the dynamics of the DMN and as such reflect the maladaptive physiology of different types of chronic pain. So that's quite a promise. So we looked at this in a little bit more detail, and here you can see that 10 studies actually reported this increased functional connectivity between the default mode network and the insula, and 9 other studies between the default mode network and some other non-DMN region, as I termed it here for simplicity. But if it is really to be a biomarker of chronic pain, it of course ought to be independent of the current pain the person or the patient is experiencing. Otherwise, we would just simply have another marker of a person having pain at the time of assessment, and we would be back to the question how useful this is. So I said we looked at these studies quite closely, and we did find that 10 of those 19 studies did report that the patients had pain at the time of the assessment, at least at this, at the day of the assessment. Some even that they had pain in the scanner. And even more, some of those studies factored that pain at time of assessment into the analysis and found that these default mode network alterations were related to the amount of pain patients were having. So this really raises the question to which degree these DMN alterations are related to having pain while being assessed, pain in the scanner, or potential DMN alterations being related more to the trait of chronic pain, sort of in opposition to the state of being in pain. So I was very fortunate that in the collaboration with Dr. Catherine Bushnell at the NIH, we were able to look at this question in more detail. So we had data available that we had acquired in previous studies on 2 cohorts with fibromyalgia, and they were very similar in many respects. So each cohort of patients had its own matched control population, and regarding age, pain duration, anxiety, depression, the 2 cohorts were very comparable. However, what was a big difference between those 2 cohorts was that one of the 2 happened to have no pain in the scanner whatsoever, and the other one had a reasonable amount of pain in the scanner. So now we had a relatively unique situation that really allowed us to investigate the question to which degree default mode network changes observed in fibromyalgia patients are pain state or pain trait related. So in the cohort that had pain in the scanner, we very much replicated the results of previous studies. So when we compared the functional connectivity between the patient and the controls, we also found increased connectivity between the default mode network and the insular cortex, as 10 of those studies had reported previously, as I told you. And you also see that here in the violin plot. We further found that in very close vicinity to this blob, it was actually the current pain in the scanner that we had carefully assessed was very well correlated with this functional connectivity change. So that really indicates that a lot of that connectivity change that is observed in the patients is related to them having pain in the scanner. So what does the situation look like in fibromyalgia patients who are very comparable in many respects, but happen not to have pain in the scanner? In the scanner pain-free cohort, you see that compared to their matched control subjects, the connectivity in this instance between the default mode network and the insula, but also any other region we looked at, does not differ whatsoever. So what we then went on doing is to actually see whether there also are relationships, not just to the current pain patients have in the scanner, but more to disease burden or variables that we could maybe relate to the state of, to the trait of having chronic pain. So anxiety, depression, disease duration. And interestingly enough, we found such a relationship with pain duration only in the cohort that did not have pain in the scanner. So it's possible that in the other cohort that had pain in the scanner, it was not that relationship might also exist, but it might not be detectable because the variance is taken up by them having pain in the scanner. So maybe here we only detected it because patients did not have pain in the scanner. Such a result, of course, also needs to be replicated before one can start to really interpret it. But fundamentally, it clearly shows the importance of differentiating between state and trait pain, which obviously also impacts the discussion on biomarkers. And it is actually possible that default mode network alterations might be a marker of ongoing pain in the scanner, which would be really interesting because imaging ongoing pain is very difficult and has been an ongoing topic in the community because the techniques are very much set up to image evoked pain, but not ongoing pain. I started this section by saying that brain-based biomarkers are an obvious option when pain itself is the issue, rather than an underlying condition being the issue. Of course, the situation could be very different when pain is clearly the symptom of an underlying condition. If in such an instance we focus therapy on the brain, potentially an underlying pathophysiology might be missed. And in this obviously on purpose chosen example of acute pain, you want to make sure that you also get the leg fixed and not only be treating the pain. So depending on where you are on the continuum, or betterly said, where a patient lies on this continuum of nociception being augmented by the brain, the importance of searching for non-brain-based biomarkers, at least when talking about biomarkers with mechanistic information, varies. But of course, it is quite complicated because in many instances of chronic pain, we do not know where on the continuum a patient lies. And actually putting the brain on one end of the spectrum is far too simplistic because sensitization processes can occur all along the neuroaxis, as we know. This is why I think it's paramount to increase our understanding of pathophysiology while searching for biomarkers, and if possible, to always target the underlying pathophysiology directly. And I want to illustrate that quickly with an example from the sensory testing field, for which it has been claimed that it might be useful in constructing mechanism-based phenotypes for meaningful subcategorization of patients. So you might all be familiar with this classical experiment that shows that hypersensitivity to heat only occurs in a primary injury zone. So that would be here. In the secondary zone around it, there isn't, we have that here, there isn't hypersensitivity to heat. In contrast, mechanical pain sensitivity goes up in the primary zone, which is here, as well as in the secondary zone. So then it should be possible, by carefully mapping hypersensitivities and differentiate between different modalities, in this instance thermal and mechanical, that we would be able to obtain mechanistic information on whether we are in a site of primary hypersensitivity or of primary sensitization, or peripheral sensitization, or central sensitization, which would be the equivalent or the mechanism behind the secondary hyperalgesia. So this is what we are trying to do in a clinical research priority program pain we have at the University of Zurich. It's still in full swings of collecting patient data, but I just want to give you one example as a glimpse of what I think could be done. So we use quantitative sensory testing, as many other groups, to assess different nerve fiber types. But what we do is that we do not only assess the most painful site that the patient indicates in a pain drawing, but an adjacent site, which is just outside where the patient experiences clinical pain, but it might still present with some hypersensitivities. And we do, of course, also have a control area. And what you see nicely in this example here is that MPS, which is the mechanical pain sensitivity, is increased in the adjacent site as well as in the most painful site. But the heat pain threshold is completely unaltered in both sides. So with such an approach, using detailed quantitative sensory testing with a certain idea about where it should be done, it is thinkable that we could differentiate different mechanisms contributing differentially to patients' pain, and which would then allow to meaningfully subdivide patients according to some potential mechanism, perhaps even across etiologies. Unfortunately, I don't have more time today to talk to you about it, but as take-home messages, I think the biomarker to choose or to aim to develop depends very much on the purpose, as I hopefully clarified. A suitable biomarker for pain might depend on the underlying condition, even in the instance of chronic pain. And I think I showed you it might be a bit difficult, but also that it is not hopeless. I thank you very much for your attention. I'm looking forward to our discussion later on, and I just want to thank our funding buddies and my research group. Thank you very much.